Adult respiratory distress syndrome is a very common entity, and we see a lot of it in hospital patients, in hospital medicine. And let's do a case and talk about the scenario. A 32-year-old man is admitted to the ICU with gram-negative sepsis. He started on double gram-negative antibiotic coverage and remains stable. The blood cultures grow Pseudomonas sensitive to the antibiotic, so you're treating the patient correctly. Initially, the patient seemed to improve, but during the second day, he developed severe dyspnea and hypoxemia. Diffuse crackles are noted on the exam, and the chest x-ray shows diffuse alveolar density. The admission x-ray was unremarkable, and I could tell you after this, the patient within 24-48 hours got worse and worse and died. So initially, got admitted for gram-negative sepsis for some reason or another. This guy was actually an injectable drug user, right? So, and then got better a little bit, a couple of days, within the course, and then all of a sudden got worse and developed, the pulmonary infiltrates, the densities, and so forth. So this is the typical adult respiratory distress syndrome that we see. And what is this all about? So ARDS is a very common disease. We see it a lot in the intensive care units, and it has to do with an increase in alveolar and capillary permeability. For some reason or other, something that the disease does, it triggers some kind of inflammatory process, people think, and it makes the alveolar and the capillary membrane leaky. That's why sometimes this syndrome was called capillary leak syndrome. So all of a sudden, maybe the gram-negative sepsis, it doesn't only occur with gram-negative sepsis, did something to the immune system in the patient and triggered this inflammatory response where all of a sudden the alveolar capillary permeability increased. What happens after that? Well, the lung fills with fluid. This is really non-cardiogenic pulmonary edema. The lung becomes stiff and non-compliant, and then the patient develops severe hypoxemia and hypercapnia, and then everybody crosses their fingers and hope that everything gets better on its own, because really, we really have no treatment after for this disease. The etiology, the most common one is probably sepsis, and the most common cause of septic-induced ARDS is gram-negative sepsis, especially things like Pseudomonas. Then there's a lot of other things, and if you look at the reference book, they give you a list of about 150 things, but the most common ones are severe trauma, any severe trauma, DIC, and overdose. These are two different entities here. DIC is one thing, and overdose is another. Overdose, we should have had a comma here. Overdose is overdose on opiates, overdose on drugs, overdose on alcohol, things like that. But really, number 4 really puts the hallmark here. Any severe disease of any type could induce adult respiratory distress syndrome, capillary leak syndrome, any type. So you always look for it in really sick patients in the intensive care unit. It usually occurs within 5 days, usually within 24 hours of the enticing disease. And what happens in these patients? They develop dyspnea, just like our patient. They develop crackles and rhonchi, and then hypoxemia, and then eventually, as it gets severe, they develop hypercapnia. On the x-ray, you find the alveolar densities. It's like a whiteout picture, all white, right, because the pulmonary edema. Now, the heart in this case is normal. Remember, this is non-cardiogenic pulmonary edema. Very important to remember that. Because if I wanted to see the pulmonary pressures in this patient, if I put a Swan-Ganz catheter in this patient, my capillary wedge pressure, remember the capillary wedge pressure indirectly looks at the pressures in the left side of the heart, they would be normal because the left side of the heart is pretty much normal. And then as I pull the measurements back, as I measure pulmonary artery pressure, that's going to be very elevated because basically the pulmonary artery pressure is so high because of what has happened to the lung. It's filled with water, right, the edema, it's non-compliant, so my pulmonary artery pressure is very high. And sometimes that also transmits to the right atrium. But that's the finding here. That's the characteristic finding. This is not pathognomonic for ARDS. You could find it with any form of pulmonary disease that puts pressure on the right side of the heart. So you could find it with massive pulmonary embolus. You could find it with interstitial lung disease. So this is not pathognomonic, but it is a characteristic finding. When you want to diagnose, you want to make sure that this is really not heart failure, the patient doesn't have anything else, and this is really ARDS. That's the way to diagnose it. Now, if you look at the literature and the history of ARDS, it was initially described actually in soldiers in the Vietnam War and then the Korean War, where these patients would, they would bring them in, they would do surgery, they look fine for a couple of days, and then they developed the non-cardiogenic pulmonary edema and died over a couple of days. Those were the first reports. From that time on to now, we really haven't made a big progress in treating adult respiratory distress syndrome. Really, nothing has changed. We treat the primary disorder. That's the most important thing. So, for example, if a patient has gram-negative sepsis or DIC or something like that, we have to treat that as best as we can. That's important. And then we give the patient mechanical support. And there's really nothing else specific in treating ARDS. The mortality, especially with certain one of these, especially the ones related to gram-negative sepsis, very high. That mortality overall has not changed in the last 50 years. That's what I'm trying to say. So you treat the primary disorder, you give them mechanical support, and really things haven't changed. There's nothing here that you could say, I'm going to save this patient. Some people are doing very interesting things. For example, they're doing this thing called permissive hypercapnia, where they're ventilating, they put the patient on the ventilator, kind of reduce the ventilation and increase CO2, so basically to cause pulmonary vasoconstriction and reduce the capillary leak. It doesn't work all the time. It doesn't seem to work on everybody. So basically, we don't have a treatment except the support and to treat the primary disorder. So ARDS may be a question when they give us a case of a very sick patient in the ICU, all of a sudden is getting better and then takes a turn for the worse, and then the patient develops this pulmonary edema-like picture. Think about ARDS right away.